Indeed, we are very lucky to have such an august company in the house. So it's time for another interesting panel discussion on Paraquat poisoning. I would like to invite the moderator first, Dr. Venkat Kola, onto the stage. Thank you, sir. And our panelists, Dr. Adarsh, Dr. Dharnindra, and Dr. Rajkumar.
Yeah, thank you. I think we had a wonderful session till now, and there is a lot of curiosity. I was happy and glad that people want to know about paraquat poisoning, the government stand, ban issues, ISCCM role, many more. So, to take this discussion, we have three panelists. All of you can have your mics, please. So, a couple of decades back, and maybe the last 2 decades, when we actually keep on receiving the patients of paraquat poisoning, believe me, whenever any patient suddenly turns to survive and get discharged, we had only two differentials. Guess what? One, he just acted, he has not taken enough. Second, probably he just threatened, he just took and spit it out. Or third, maybe the brands, and we talk about the generics and the quality of the molecule. We hardly saw any patient who actually consumed a lethal dose of 30 ml of 20 or 24% of paraquat hydrochloride and gone into organ failures and survived. So that's where we thought about this as a death sentence. If anybody with a paraquat poisoning came after the window period of maybe 4 hours or 6 hours, which is a routine rule, somebody consumed will come to the hospital maybe after that only. Anybody calls us, we say it is a death sentence, don't come. These are the only referrals which we try to avoid. People call across from Guntur or somewhere. We say, don't come, there's not going to help. So is there any change happened in the recent times, including one of our panelists, Dharanindra, had a series of cases. We as an organization institution had a series of cases. We wanted to bring those discussions here. That's why we wanted to see, is there any paradigm shift? So to take this discussion a little deeper, let us first understand from Dr. Adarsh as a first part, how frequently you see this paraquat being a toxicological toxidrome coming to you, your hospital, or your experience with that, and what is the common presentation to you?
Thank you, sir. So, uh, I being working at a tertiary center where it's most of the cases I receive is a referral center. So, I would say 14 to 20% of it toxicology cases is of paraquat consumption. But the main crux is the timing of presentation. By the time we receive the cases, they would have been out of that window period where the therapeutic benefits are no more. So as there are multiple multimodal therapeutic modalities that we have, so we have to initiate and wait for the response. But
So,
largely, if I say in India, again, the statistics say around 14% is what the paraquat poisoning among all the toxicology. Predominantly, it is the age group which is between 15 to 60, mostly the men. And as we know, the mortality is somewhere between 40 to 80%, depending on the time and the time of the presentation.
so very interesting information that around 20 to 30% of the cases which are received by tertiary care units are paraquat poisoning. You can see this map, a lot of work done by Dilip Kumar Reddy. He published a huge amount of data. This is done across these states, which is very prevalent of paraquat poisoning. And this gentleman went on doing the survey, talking to the farmers, retail sellers of these insecticides, and also healthcare associates, also the government agencies, and he has done a very extensive research. And these are the indications for this paraquat. And you can see there are a lot of work going on. We were talking about societies like ISCCM. We're talking about societies here, Pesticide Action Network. There's a Pan India, Pan Asia Pacific. And there are some declaration like antimicrobial resistant declarations. And this is the slide which talks about there is a rise in use of pesticides, and there is a rise in pesticides, paraquat being a common presentation in some of them. And what can be the reason why there is a surge in the increase in use of a paraquat over a time? These are the answers which were been seen. Now, if you see, the consumption is close to 5 to 10% of the whole pesticides used. The reason is it is a cheaper. It is cheaper than others. It is more effective than any other alternatives available. There is unavailability of a labor. All are migrating to the urbans for your all infrastructures. So there is no labor manpower available to actually take care of these weeds. So less wastage or a labor wastage and no particular data. These are the different reasons which are thrown. One interesting component which Dharanindra was talking to me when I was discussing about weed resistance, like antimicrobial resistance. Dharanindra, can you throw some light on that?
Yes, sir. Uh, Actually, when we were talking to farmers across the Andhra Telangana areas and the border areas, just like antimicrobial resistance, there is weed resistance. So weeds are weedicide resistance. So what is happening is we are seeing a lot of resistance of commonly grown weeds in agriculture. So that was because of inaberrant use. Just like the antibiotics, if you are using all the common antibiotics unnecessarily, weeds are also gaining resistance to normal non-toxic weedicides. So one farmer was telling that 10 years back, simple compounds like glyphosate, the weeds used to die. And when I asked him, why are you using paraquat so much? He told that the weeds are not dying anymore. They're not dying with simple herbicides. They are not dying with glyphosate compounds, which are less toxic to humans and animals. They're using paraquat more and more. And there is something called superweed, just like a super bug. There are super weeds now. So all your mango crops, apple, all these crops are prone to super weeds. And the only compound that is killing them is paraquat. And the problem is paraquat has a residual half-life of 20 years in soil, in water. And this paraquat is inking into the soil and going into the groundwater supply as well. And it's going into all parts of the food cycle, food chain.
So before they exposed to a intoxication by a self-inflicted maybe consumption, these are the different reports of what they feel when actually they use this paraquat. From abdominal discomfort or breathing difficulty, these are the different farmers who actually expressed themselves. So coming back to Rajkumar, it's straightforward when a patient comes with a container and talks to you that it is a paraquat poisoning. It happens to me in many times that we able to recognize that it is a paraquat poisoning after 5 6 days after we ruled out many medical conditions. How do you suspect them when an unknown case comes to you without any clinical history?
It's easy when a like patient comes within few hours of presentation, because usually the family members or the other relatives get the patient out of anxiety. But it is really challenging to a clinician when the patient comes very late and not reveal any data regarding his history of consumption. So you need to examine him clinically. The one feature is that he might have a classic erosions of the tongue with lot of slough on the tongue, with difficulty in swallowing. The second thing is organ involvement. See, the corrosion injury can happen with even acid consumption, but organ involvement along with corrosion injury of the tongue should pinpoint to paraquat.
So, very interesting comments. It happens to many of us, including me, in my last organization, when a young girl of around 16 years is transferred to us from nearer and about East Godavari, saying this patient had a multiple organ failures, hepatopathy, AKI, and having some breathing difficulty, evaluated in the line of a autoimmune disease, transferred to us. The patient, when is reached to us in initial days, we saw that the patient was having a lot of pulling of secretions. Day one, day two, there was no much of oral ulcerations. As we know the mechanism of action, which may take a couple of days to evolve, later on we could realize that the patient had a tongue coated with an ulcer, which we say a paraquat tongue, and the day three. And when we did an endoscopy, we could see a corrosive injury all throughout. And unfortunately, this patient is a very known family member of a police commissioner. So we didn't dare to even do an MLC and ask. When we later on expressed this all and inquired, after 5 days of the whole presentation, we could found a paraquat bottle in her room. In spite of all this, the girl denied that she consumed that. After 1 or 2 days of repeated counseling of the family, they agreed. So this was actually labeled as a medical condition in many situations because initial couple of days you may not have those erosive injuries which are seen in the airway. It's actually manifest more commonly after day 2, day 3, when you actually deplete all your NADPH. It may not be direct corrosive acid like phenomenon, but it is because of a tissue necrosis which happens. Coming back to the discussion which we had, Dharini, there were a lot of discussions about banning it. So interesting, there were a lot of litigations related to this. Countries like Sri Lanka has banned. Countries like Maldives has banned. 67 countries has banned it. Except you can see India is left around it, and it is one of the country where the consumption is high. What is your take on that?
Sir, actually, starting with, I want to express that the country that is producing the most amount of paraquat, that is China, it is banned in China. In few areas of China, it is completely banned, and it is producing it for the world. Number two, the largest producer apart from China is United Kingdom. In United Kingdom, you cannot buy paraquat. It is completely banned. It is produced by Synergia Limited there, and only in one country you get paraquat on Amazon. That is
So
India.
ma'am was confirming, we are confirmed that
So
we searched in Amazon.
it is for 45% off for 269 rupees, 500 ml. 20 ml is enough. 500 ml bottle can kindle an entire auditorium.
It's a clear vid or something. The brand is some
Yeah. So thing is, it is
all
all
clear,
clear,
all clear. Right?
all clear. So what is happening is in India there is a very poor stewardship, very poor stewardship for agriculture pesticides. So even a person who is not doing any agriculture, not owning one ounce of land, can just randomly go and buy. And actually, Odisha is actually leading the model here. They have banned paraquat for majority of their crops, and even if you want to buy paraquat in Odisha, you will be only sold in limited quantity and proportionate to the amount of land you want to spray, and it will be monitored by local tahsildar. And the same model is being adopted by Kerala. Except these two states, all the other states are not following any regulation or ban on any kind of molecule. And European Union has completely banned it. And coming to the usage, why are these people using it? I'll tell you, it is a contact weedicide. It works in the soil so that the weeds even don't grow. So you don't need to do tilling of the soil and apply that. It's very less labor intensive, as sir was saying just before. So you can use, and many people are using it for land improvement effects. For example, they are acquiring
Narendra,
land for airports.
to cut it short, we'll take it from the leadership of ISCCM. Sir, we are seeing this is the state which uses the most in the country. Um, as we have seen, there are many societies which are already working on it, and there are many governments also started regulating it. Should we be the city or a branch which should actually initiate? And in your leadership, should we take it forward so that these patients don't come at all? Mike's just
So in an agrarian economy like ours, where 70% of the population depends
Mike,
on
sir.
70% of the population depends on agriculture for sustenance, it is impossible to ban a cheap, easily available, most effective weedicide, which in the farmer's perspective is life-saving for him. Sit, us sitting here in a star hotel talking about banning paraquat at is preposterous. We can't even think about doing it. What we can do is, I think Pragyan from Odisha is here. Um, together,
Regulate it.
I think all the branches of ISCCM can represent to the Department of Agriculture to adopt the Odisha model of regulatory sale of paraquat. But what have we done with antibiotics? There is regulatory sale of antibiotics. Have we not failed spectacularly? We'll fail here also. So, as a society, as professionals who see the sickest of patients coming and dying, maybe with 60% mortality in the good hands like Dharanindra, it may be 50% mortality, but mortality is high. I think we should take it as part of our responsibility. You can call it social responsibility or professional responsibility. We go to the villages, we go to the periphery, we speak to the Tahsildar, we speak to the village medical officer, we speak to the Mandal revenue officer, get the opinion leaders among the farmers. The farmers will not listen to a Srinivas Samvedam or a Venkatramana Kola if you say don't use paraquat. They will listen to a lead farmer who has been an example to them. They will not listen to you and me. So we should train them, tell them that, look, this is the disaster which Paraquat, in my tenure, I'm looking forward to having more such penetration into the community to spread the problem of yellow phosphorus, the spread of problem of Paraquat, supervasmol into the small towns and villages of this country. If we can do that, I think one lifetime we would have done enough for uh, justifying our survival.
Yes, sir. Thank you, sir. We look forward for that. Others, just a continuation of your talk, what do you think is the lethal dose, time of presentation? Generally, what is the time of presentation and what is the expected mortality?
Yes, sir. Putting all these 3 points together, so as per the literature, it is around 20 to 25 ml of 20 to 24% of the paraquat consumption is enough that there is a 90% mortality, sir. But it depends on the time of arrival to the appropriate center where they have most probably the hemoperfusion is the one game changer which they can be let them live for long, and the dialysis again it's only the prolongs the mortality, but again the hemoperfusion is the main game changer.
Generally, what is the timeline at which they present?
Yes, sir. So usually since the time of consumption and arrival to a center, if it is less than 4 to 5 hours is the when the golden period is where we can let the patient live.
So very interesting that we all thought about that the 4 hours target or a 6 hours target is too difficult to achieve. Recently, when we started talking about this in a tier 2 cities and smaller towns, we have seen ki these are the areas where the hospitals are putting a seat, doing a first cycle of hemoperfusion or a dialysis, sending them, and we are receiving them in the same frame of between some 8 to 10 hours after one cycle, which is a new change which I was not expecting to happen, but it is happening. Rajkumar, just to take it forward, how do you approach these cases? He gave some hints. How do you approach these cases? Do you put a Riles tube? Do you use activated charcoal? Do you do a gastric lavage? The key 1, 2, 3 messages on this.
If the patient presents to us very early, like if I'm working in a very center near to a village, within 2 hours if he comes to me, then probably I would insert a Riles tube and give an activated charcoal. But if he presents very late to us, the insertion of Riles tube doesn't make any difference. Endoscopy, yes, like it can be, if the patient presents very late to the hospital, it can be done to assess the corrosive injury to the esophagus as well as to the gastric part. And the hemoperfusion, as he told, is a game changer here. If he presents early to the hospital settings, like within 4 to 6 hours, we can give a hemoperfusion, which usually showing good results. Hemoperfusion along with hemodialysis has shown more better results than hemoperfusion alone.
So just to take it forward, Dharanindra, can you just elaborate on, are we having a shift on paradigm? Does hemoperfusion, hemodialysis in a timely manner is the game changer here?
So actually, I'll tell you, from 2020, when I started the practice there, uh, when we used to see a paraquat case, our first initial response was, oh my God, we used to give them a negative counseling, 100% mortality and all that. And once we started doing our first few cases, what we have seen is patients coming in the first 3 hours, 4 hours are doing good. As sir was discussing, 50% mortality reduction we could achieve. And the earlier the hemoperfusion, the better the prognosis was, general prognosis. And we felt that the only way to send an early referral was, as Samvedan sir was telling, farmers only listen to the people who are they habited to, their leaders in their skin. So once we go and talk to them, talk to the local people, they started sending us cases earlier. Before, what they used to do is we took the help of IMA, and leaders in IMA used to help us triage cases and shift early. Before, they used to waste a lot of time by putting, local decontamination, which was time waste and not working. So working at the grassroots level is going to change the game. So I just wanted all the intensivists to step out of the ICU, go to the grassroots level, talk to them. That will fetch a lot of benefit.
So adding to that, the confirmation and availability of it in the blood had no direct measurement of paraquat serum levels. We don't have any way. But now we have a confirmatory method of identifying paraquat by diethionate test in the urine. And there is a kit which is available with this, some of the hemoperfusion sets which we can do. So how do you actually do hemoperfusion? What is the number of cycles you do? How you actually test them?
So actually, it is very simple test. We use the urine diethionate test, and what we have targeted is a door to hemoperfusion time. So a door to hemoperfusion time of 30 to 40 minutes can be achievable even in the lowest of the lowest centers. I'll tell you. In our center, like for example, when the patient comes, we do the urine diethionate test within 5 minutes. It just requires sodium hydroxide to alkalinize the urine, and thereby then we need sodium diethionate. So we just add sodium diethionate to alkalized urine, and you'll get the test positive. So if there is paraquat, you get blue, and if there is diquat, the mixture turns green. So once you see that, we waste no other time. So we have an emergency billing system. Very minimal bill. So we immediately do the right femoral access and we start the hemoperfusion. And we can do it in the ER itself, emergency room itself. And what we have seen is,
How frequently you do it after
yeah,
that?
first thing is each hemoperfusion is 3 to 4 hours. After 4 hours, the catarrhate gets saturated. The first hemoperfusion, the catarrhate gets saturated very fast because of the lot of burden and the lot of toxin burden in the blood. So the second and third hemoperfusions, we do it when the urine diethionate test is still positive. So urine diethionate test is a bedside test. You can repeat it as many times as you want, and it's very cheap. So after the first hemoperfusion, within half an hour, we draw a urine sample, we test it again. Again, it's positive. So we redo the urine, we redo the hemoperfusion. So we have done maximum for one case, we have done 7 times. So the patient came out fine.
So is it possible that urine diethionate test is negative in after one cycle and it comes back positive after 8 hours or 6 hours, it resecretes back?
Absolutely, because
So
in obese patients, especially obese patients, it comes back negative after the hemoperfusion, and after 2-3 hours, the compound in the fat solvent comes back into the blood and it turns the test positive.
these are the different SOPs, protocols, individual institution has adapted. One of those same kind of code paraquat is adapted by us with the targeting a 30 minutes of hemoperfusion assessment, and we repeat in the same way of 4 hours. We used in between 3 to 8 number of cartridges in them, and we had a series of 14 to 15 after the last couple of years experience. We had around 8 survivals which are followed in the last 6 months, and all of them had multiple organ issues on organ failures involvement when they have been reaching to us. But yes, you made a very important point. Awareness of the local medical facilities has had a game changer along with the hemoperfusion. So it's very on the dice, it is very easy to say they should be reaching to you in 4 hours, 6 hours, 8 hours, but many of them reach late to you. And how do you handle them there? And another point, many of them don't have urine also. How do you test them?
Excellent question, sir. We had one case wherein, despite all the efforts, the patient reached at 8 to 9 hours, and we put the Folase in, and the first drop of urine that came was blue tinged. That patient doesn't even require a urine diethionate test. His tears were blue in color. I mean, the Folase, when you put the first urine drop came blue. So those patients didn't require urine diethionate also. And that patient, that young lady, we even told the family that it's useless. You're already late and the concentration is supra threshold. But, they were the young people, the entire family, the village elder were asking us, do something. Even if she is gone, at least we'll have satisfaction that we tried. So in that young lady, we had initiated hemoperfusion. She required almost eight times hemoperfusion and hemodialysis simultaneously. As you were discussing, we kept the hemodialysis filter and hemoperfusion. There was no urine, so we had to do hemodialysis as well. So hemodialysis, hemoperfusion, we did together. That lady has come out to survive. And what happened was that lady had developed AKI. AKI was there for 3 to 4 weeks, and
And
she was
when did
having
it
pulmonary
recover?
fibrosis also.
Hmm.
And she was having room air saturation 78, 84, 82. She was young, maybe she tolerated, that's why she tolerated. She's on MHD till to date, she's on MHD. We are actually trying to find a source for our lung transplant.
We have seen some of these AKIs recovering after 4 to 6 weeks also slowly. There was another interesting question asked to us from the peripheral center. I don't have hemoperfusion cartridge with me. Can I do a hemodialysis to start with? The answer is yes.
Yes.
So can you comment on that?
So basically, what we are doing is, this is molecular weight of paraquat is almost 27,000 to 35 kilothousand Daltons. So in order to remove this kind of high molecular weight substance, you need something like a hemoperfusion, a cartridge, hemoperfusion, hemoabsorption phenomenon. But many a times when you don't have the cartridge, you can start with your common dialysis filter and wait for the cartridge. So although it might not absorb everything or it is not
So
as efficient,
it's a low protein binding. So Dalton's is one, protein binding in the other, volume of distribution. These are all
factors, yes.
the factors which we use for our filtration. So because of its low albumin binding, some of it can be removed till a cartridge is available. There were
Exactly,
some
yes.
flows given for the severity. Where do you find that this patient will not make, as you said, higher the dose? Probably, as Deepak said, the molecule has to be available in that. The other point is the quantity, timing, and all. At what point you will say probably there is no point in doing all this. It should be only a palliative care.
Actually, the severity data is all coming from one center in Iran, Professor Mohammad Yunus. He has classified paraquat poisoning cases into 3 phenotypes. So it is alpha, beta, and delta. So it is classifying the acute toxication into 3 categories. So patients with gamma phenotype are the most severe. So they are having anuria at presentation with evidence of SIRS and multi-organ failure. So these patients do very badly. Their mortality is 90%, and beta is less benign. They don't have AKI, but they develop AKI after arrival. So these patients can, we can salvage them, but they'll end up with some residual organ dysfunction. And these are the patients that will be referred to higher centers for lung transplant, renal
Yeah.
transplant.
So what is our experience is if a patient is already in a severe hypoxemia and you are into some or other form of supporting systems like needing a ventilation, not maintaining oxygen and hemodynamic is stable. I've not seen any of those patients surviving provided you support them with some alternative support. AKI, LFT dearrangement much before the patient landed into some of these artificial ventilation support has at least reasonably holding on, but not the other. Dr. Rajkumar, there were multiple individual practices, even in UpToDate talks about all of them, but puts a very caution word. High dose of cyclophosphamide, pulsing steroid dosing, many more. What is your take on that?
Initially, the smaller studies have shown immunosuppression a good mortality benefit, but later on the evidence has come through and meta-analysis even suggests that there is no mortality benefit of using immunosuppression like cyclophosphamide, pulse doses of steroids. But you can use dexamethasone if there is a lot of airway edema related to corrosive poisoning.
So that's what 8 milligrams of dexamethasone thrice a day is the highest dose recommended by.
Actually, I just wanted to add one thing
Yeah,
to this. Actually, why the steroids don't work in improving prognosis is, or organ function is, the damage is para-inflammatory. It is not
not
inflammatory method
inflammatory.
of damage. It
Agreed,
is
agreed.
like direct mitochondrial injury, and the cell is the cell is going into apoptosis, not necrosis. So it is bypassing the inflammatory pathway, para-inflammatory it is.
Okay, others like COVID, when nothing works, many things comes into picture. Vitamin C, vitamin E, NAC, many more antioxidants, immunonutrients. What is the role?
So, so when we talk about the therapeutic options apart from the dialysis, hemoperfusion, and all that, steroids. So these are the ones which, as a multimodal treatment options, we have. Why? Because the main effect of paraquat in the body is it causes all the cell destruction due to redox cycling, more of the oxidative stress, more of the reactive oxygen species, free radicals, and all that. So when it comes to N-acetylcysteine, it produces, it increases more of glutathione in the body, which helps in all these steps where the damage is happening, like vitamin C, vitamin E, and there are also reports saying that desferrioxamine was also used. And there is one more molecule, I think, deravumab or something like that. So all these are Chinese literature, what we have till date.
So there's
Yeah.
some scientific logic behind all this, but none of them has proven to be beneficial. Some of us use N-acetylcysteine because, like any toxin-induced liver injury, it may have a beneficial role to play. Oxygen threshold.
Yeah, so
So we all know okay, it's an oxygen-free radical mediated injury. At what point you are trying to supplement oxygen? We don't do oxygen supplementation at till a point. What is that threshold you want to define?
I will answer the question specifically, but with one case example. So what happened was we had one 16-year-old kid who consumed organophosphate and paraquat both. So this kid developed acute cholinergic syndrome. And we started on hemoperfusion, but he developed acute cholinergic syndrome. We had to intubate and ventilate him. So we ventilated the patient. We just ventilated the patient. We ventilated him on just 0.21. On room air, he was being ventilated for the entire acute and cholinergic syndrome for the 3 to 4 days on 0.21.
5 more minutes.
And we tolerated oxygen saturation of 80 to 84. Of course, he was a young chap, so he tolerated 88, 89. So target is 88, 85.
So we don't supplement somewhere between 80 to 85. Below that we supplement. It's a different threshold, but yes, you accept permissive hypoxemia, whatever it
Yes,
is.
absolutely.
Till your lactates are okay, your cells are getting some or the other form of oxygenation, we are trying. Rajkumar, fashion nowadays, ECMO being a talk of the town, many conferences, more than critical care conferences. So what is the role of VV ECMO? Many patients now after COVID say, put ECMO, give a lung to him.
So like as any case scenario where there is low oxygen levels, we can utilize VV ECMO in this scenario also. But before like initiating, you should always try to talk to attenders and tell them that it is bridge to transplant only. And even the continuation of VV ECMO, even it might take more months also, because it's a bridge to transplant. For the preparation to transplant and prevent the other effects, you need to wait for at least 2 to 3 months on ECMO and then go ahead for the transplant process.
Thank you.
But
Yeah,
One
yeah.
thing to
Others
add here.
wanted to add anything?
Yeah, one thing to add, sir. Actually, for acute hypoxic respiratory failure management in ECMO, there was some case series from DMC Ludhiana, sir, and Dr.
Dr. Vivek, huh?
Dr. Vivek's experience. He's saying on ECMO also used to tolerate permissive, cut the oxygen
Okay.
just keep the oxygenator. Even he used to keep the oxygenator on very less FiO2, very less FiO2.
So it's a big, as I told you, continuation to you, Dharanindra. Ki, whenever we counsel the family, the lung has gone damaged to beyond the repair, they say, sir, replace the lung. So roll of it.
See, majority of the paraquat cases that we have seen in our profile were young people, and they came from different socioeconomic backgrounds. And lung transplant is life-saving for them. And these beta phenotypes that come, in borderline area, 5 hours with significant consumption, who are hemoperfused in the borderline zone. These patients end up being respiratory cripples or renal cripples. After the ALI, everything settles down, they will be like bed bound. They cannot walk, they cannot go to the toilet also, just because they become breathless. So there are a significant amount of patients like that, but there is no state sponsored lung transplant program other than in Tamil Nadu, and these patients are somehow given less preference.
So there was always concern. So we had a 2 lung transplants which are alive in the last year when we did on a paraquat. It is rare reported cases. We had few from Canada and we did last year 2 transplants. But there was always a question: is the paraquat still there in some part of the body? Can it attack the new transplanted lung too? So what is the duration you look after, and do we have any serum paraquat levels which are sent?
It's an excellent question, sir. Actually, paraquat half-life is 20 years ex vivo. Ex vivo is 20 years, and in many of the areas where they use paraquat extensively, especially in mango farming, they have found paraquat levels in the fisheries, in the water also, in the water, in the fish that they eat, in the shrimp that they grow. So it is there in the food chain, sir. And if you're eating seafood not related to agriculture also, it's still in the food chain already. And in vivo, inside the human levels, how many years it's going to last are is an area where we need more studies. But ex
Found in
vivo
the
it is 20
graphs
years.
also,
Yeah, it is
the
found in the
literature.
graphs, but the the relief here is the majority of the concentration is gone, and it will affect the graph less likely.
Okay. So just take home points in view of a time. Dharanindra, you said one should not do these things in the first 4 hours. Take home.
So to conclude the session, we wanted to focus on one thing: what not to do in the first 4 hours. So what not to do in the first 4 hours? First thing, if the patient presents to you in a delayed way, already 4 hours at home, time wasted. In that patient, don't attempt nasogastric lavage. The compound is already in the small intestine. It's already gone. It will get absorbed. There is no way that you can rescue it with the Ryle's tube or any of the gastric decontamination methods. Number two is if you have a simple dialysis machine, your brown simple Prismaflex 4000. If you're having the simple dialysis machine, you can do hemoperfusion. So before you, if you have a nephrologist, if you have the capability, do the first cycle of hemoperfusion before you send to another center. Why I'm telling, because what happens is you don't want to handle the mortality or the morbidity associated with the case in your center. At least you can do one episode of hemoperfusion before you ship the case to the higher center. Number three is don't use oxygen. If he's a young patient, he can tolerate hypoxemia 85, 88. Make sure he's monitored by a paramedic and send him. Number four is there is no role of NAC, steroids, or any other supportive medications. Extensive literature review we have done. We've taken the help of Saman sir also. There is no supportive evidence for extra medical management, especially in the acute phase. So it's all just time wasting.
Okay. Any take home point from you,
No,
others?
sir. The first, the main crux of the discussion we have, is there any
Prevent.
paradigm shift?
Uh,
So these are the points which we have to consider as a paradigm shift, at least what the literature and what the evidence and what the resources we have.
Early hemoperfusion,
Yes,
if not
yes,
at least dialysis, then combine.
exactly, sir.
Okay. Any take home point, Rajkumar?
Uh, like if there is a hemodynamic instability, usually the preference to start a VA ECMO in the initial stage is more. But what our case reports are showing that if you go ahead with VA ECMO rather than VV ECMO, the mortality is more, the bleeding chances are also more. So if you can initiate VV ECMO in that hemodynamic instability also, it has improved over a
Yeah.
period of time.
So probably the message is in a hypoxemic patient, you improve hypoxia, automatically hemodynamics get stabilized and it optimizes. Okay, I think wonderful discussion. Thank you. It's a learning experience for all of us. Thank you all the faculty member. They should get a big round of applause. I hand over to you. Thank you.
Valuable exchange of ideas. Now I request Dr. Venkat Kola to hand over the mementos to our panelists. Dr. Adarsh, Dr. Dharanindra, Dr. Rajkumar. Please give them a round of applause, please. इसके बाद break. I thank all the speakers and I now request Dr. Shyam Sundar to give away the memento to Dr. Venkat Kola.
Thank you, Dr. Venkat. Shyam sir. I think we have reached to another important session, that is lunch. So, so I don't want to delay your lunch. So we'll break for lunch. But sorry for hurrying you. So we'll meet exactly at 2 o'clock here. So because we are already one session behind, so we don't want to, carry it in the evening time. So please join us exactly at 2 o'clock. Thank you.